Hi, a very good afternoon, everyone. Thank you for joining us today for our webinar. My name is HHAN, a research assistant at SSR, and I will be your host for today. We are honored to have Professor John Eastwood share his team's critical realist evaluation of Sydney's Healthy Homes and Neighbourhoods initiative. In recognition of this initiative's success, his team has won the Prime Minister's Award for Excellence in Public Sector Management in Collaboration, as well as a New South Wales Health Award. Professor John Eastwood is a clinical professor and executive clinical advisor for the Sydney Local Health District. He's also a public health physician and pediatrician on New Zealand's Southern District Health Board. We also have with us Dr. Robin Tan, our research fellow at SSR, to moderate this session. Before I hand my time over to them, I will make a few announcements. First, we are streaming this on Zoom and recording this session live on our SSR Facebook page. Once the webinar is over, we will upload a recording on Facebook, where we also have recordings of our previous webinars. By participating in this Zoom webinar, you consent to this recording and for SSR to use it for publicity purposes. We hope that you will ask questions on the speaker's research. We will send a pigeonhole link in the Zoom chat later, where you can post your questions. If you see a question that you like, you can vote for it so that it appears higher on the list. In the later half of the Q&A session, we will also be opening up the floor in the Zoom room, where you may turn on your camera and microphone to ask your questions directly. However, we will not be taking questions from the Zoom chat and the Facebook comments section. As we have a limited amount of time for Q&A, we apologize if we are unable to address some of your questions. Please stay on after the Q&A session for our feedback poll. Finally, registration for our workshop on participatory research for social services is open until the 17th of June. Do scan the QR code on the screen to find out more. With that, I will now pass my time over to Professor Eastwood. Thank you.
Good evening and tēnā koutou katoa from Aotearoa, New Zealand. I'll now share my screen and start my presentation for you. Just go up. So I'm going to present to you this evening on a large body of work that began in 2007. It's a realist design, research design evaluation, and this one is of Sydney-based Healthy Homes and Neighbourhoods Initiative. It's a critical realist translation or social epidemiology project, and you'll find some papers written with that heading. The overview of tonight's presentation is I'll present to you Healthy Homes and Neighbourhoods as an initiative, its aims and components, a very brief summary of what is critical realist evaluation, and feasibility phase of the realist evaluation. The research was conducted in Sydney. Sydney is a city divided between the rich in blue in the northern part of the city and the poor in the west and the south of the city. This research was undertaken in central Sydney, where it's a bit more mixed.
Sorry for interrupting you, Professor Eastwood. Are you able to share the screen, or would you like me to do it?
Oh, am I not sharing? Oh, I thought I had done that. Got it. Here we go.
Okay, yeah, you can see it now.
Try again, here?
Yep, it works now. Thank you.
Okay, so Sydney is a city divided between the rich and the poor, as you can see here. The aims of Healthy Homes and Neighbourhoods was as a long-term care coordination for vulnerable families with complex health and social care needs, who are disconnected from key services and who require multi-agency support to have their needs met. The aim is to keep families clients and their families safe and connected to society. The earlier research started in 2007 and was an emergent mixed method study using critical realist methodology. So I'm not presenting that tonight, but the theory that was constructed during that earlier research was used to inform the design of this translational intervention. So a collaborative co-design was undertaken in both 2013 and 2014, which resulted in the community and its partners agreeing that we should strengthen our home visiting programs, that we should have integrated community partnerships and reorientation of services. This has been published in the International Journal of Integrated Care, both the original co-design from 2013 and secondly, the design of Healthy Homes and Neighbourhoods in 2014. In 2014, the New South Wales government called for expressions of interest for funding for an integrated care initiative, and a tender document was sent in, which is the one on the left. At the same time, the district was conducting a collaborative approach to child health and wellbeing. The core components that we proposed in our tender document, there were 9 of them, to identify vulnerable families, to have care coordination, to use evidence-based interventions, to work with general practice, to use health promotion approaches, to have place-based hubs, to change the way we were doing everything at a system level, and finally to monitor outcomes and to do a complex intervention. There was a theory of change developed at the time, which I will not go through in detail. This theory of change was developed in partnership with our social services. There was a child health and wellbeing plan, which focused on interagency action between health education, welfare, and our primary healthcare networks. A key feature of this plan was to have a demonstration project, Healthy Homes and Neighbourhoods. Just to reiterate the core design components of the program: care coordination, supporting sustained nurse home visiting, using wraparound models of care, using family group conferencing, working in partnership with general practice, place-based initiatives, having a health promotion component called family health improvement, targeted parenting programs, workforce development, and outcome and realist evaluation. I cannot present all of that this evening. I'll just choose a few selected components. So the model, in summary, has got these components: local hubs, which is our place-based initiatives, general practice engagement, family health improvement components, and all of that wrapping around family coordinated care and system change. This is perhaps, given the nature of the audience this evening, I'll just focus a bit on this slide. The approach was family-centered care coordination. That is, we would identify families with needs. We would work in partnership with the families to identify their needs, to help them develop a plan for their family, assist them to engage with services, and then to review how they were achieving their personal goals as a family. The sort of interventions we had, where we're using family partnership approaches, which is, you can look that up separately. That's from Hilton Davis from the United Kingdom. We're using shared care planning approaches in partnership with our partners. We're using clinical case-based reviews, where we're using health pathways, which you can look at that separately. That is a way whereby the health sector is designing and communicating with each other on what the pathways are. The place-based initiatives, we have a complex community. There's rich and there's poor. We did some spatial mapping, which this paper has been published. You can find that in the International Journal of Integrated Care. And you can see that we've identified a pocket of high need in the suburbs of Redfern and Waterloo, and another one to the other side, a Punch Bowl in Riverwood. These became our two demonstration place-based initiatives. The Redfern Waterloo place-based component is within a high-density social housing complex with a very, very high Indigenous Aboriginal population. And we worked directly with the community and the local services in partnership to identify community needs, to provide care coordination from a site that was in the base of one of these social care services. And we also developed a project for behaviourally challenged children at a Green Square school. Now, I'm going to talk briefly about realist research, design and evaluation. This is not exactly the same as Pawson and Tilley's approach to scientific realist evaluation, but obviously there's an overlap. And I may not have time tonight during the presentation to draw out the differences, but you might wish to ask me in Q&A. So our approach to realist research, design and evaluation has recently been published in 2021 in the second edition of the Handbook of Integrated Care, Chapter 37. And some of our thinking around integrating perinatal and infant care, which is not all at Healthy Homes and Neighbourhoods, but it has got some elements of it, is published in Chapter 38 of the same book. You may also be interested, given your professional and research backgrounds, to read another chapter in the same book on integrating health and social care. Realist ontology, the understanding of the world at the world view, is got an ontological depth which starts with the empirical, which we can actually see and touch and perceive. The actual, which is that which happens but which we didn't actually experience, such as the tree that fell down in the forest but we didn't hear it and we didn't see it. And then the real, which is the mechanisms and structures in society and social, us as social beings, that is generating these phenomena. Those of you who have academic discipline in this area will be familiar with structure and agency. So the mechanisms are the underlying forces that are generating what we observe. And I'll come on to some examples later. For those who are familiar with implementation science, you'll know that we develop logic models which have inputs, activities, and outcomes, and that we have an intervention theory about how our intervention is going to produce the outcome. A realist approach to this goes further, and it actually gives consideration to what are the hidden mechanisms that actually stop or enable the inputs to produce the activities or the activities to produce the outcomes. So this is briefly discussed in one of those papers that I showed you earlier on the design of Healthy Homes and Neighbourhoods. The other aspect of the realist ontology is that reality has not only got the depth of empirical, actual, and real, it's also got depth in terms of atoms, physiology, the mind, that is, and then you've got the self, the situated activity, which is where people interact with each other, the setting, which might be a part of your city, a hospital or workplace, and the context, both economic and social. So those of you who study the social determinants of health will see some similarity here. Those of you who are familiar with Pawson and Tilley's work will notice the diagram 4B, which is how mechanisms operate within a context to produce an outcome. It's important because I didn't realize this myself. The outcome is actually a change from the original state to the subsequent state. So it's a change in regularity. Now, a lot of my work is informed by Denmark And it's the same idea, though, that mechanisms produce effects, but they are conditioned by other mechanisms that are operating, which is, again, context. This is a busy slide, but just to acknowledge that it is a cycle, that what we do is we do some research in the field and develop an initial theory. We then test that in the community with data collection, and then we synthesize that, and then we modify our theory. So it's a cycle, continuous cycle that is happening. And so consequently, there is a realist research part of the circle. There is a design part of the circle, which is the bit at the top where we're refining the model. And there is an evaluation part of this cycle. Again, those of you can ask me later about how, what are the methodological methods that are used in realist research. But in our case, we were using mixed methods, and then we were using forms of retroductive theorizing. Again, we published a paper on that, which is where we're looking at what is it that could have caused the outcome that we observed. So these are the evaluation protocols that I was referring to earlier. Sorry, it wasn't the design ones. This is the one. So if you're looking for some of these diagrams that I've shown you, you may find them in these two papers. So finally, I want to talk about the feasibility phase, and I'll make a note to myself that I seem to be on time. I've got not ahead of myself or behind. So I'm only going to present to you some of the methods we used. And some of the work we're doing is very, very challenging. And I'll briefly comment on some of that. So we're basically using a quantitative method called interrupted time series. We would like to have a control group, the counterfactual. And so we're using something called propensity score matching to identify that. And it's quite challenging because of the nature of this complex intervention. We're using patient-reported measures. The use of these measures in this context is also very challenging, and we've recently published a paper on that. And then there's a qualitative critical realist interviews, which I'll present. We're using a modified version of the Medical Research Council's model for designing and evaluating complex interventions. We're going to present tonight just on the feasibility phase of this. The development phase I've briefly already discussed. The full evaluation phase we have funding for, and we are starting that research currently. So I mentioned the interrupted time series. You can see the enrollment in integrated care occurred there in a 12-month period, and this is hospitalization that could have been prevented. And what we're demonstrating here is that at that time that we did this, this particular bit of the study, we showed a reduction in hospitalization, perhaps. Now, this is only indicative. It's not got a control group. And so we can't look at statistical comparisons between our time series and a control group series. And we're actually attempting to do that at the moment. The patient-reported measures, our clients had adverse child experience scores where a significant number of them were greater than 12, and 85% of the clients scored 4 or higher on their ACE questionnaire. So we have a separate study going on looking at adverse childhood experiences. The parents' depression levels were assessed using the DAS-21. 27% of our clients demonstrated a reduction in depression, 64% in anxiety, and 45% in stress. quality of life would have been a good outcome measure for us to use. There has been a lot of challenges in actually having our clients complete these scores and scales, and you can read about that in that other published paper that I mentioned. So 63% of the clients that we have data on indicated that their quality of life had improved. So those are the quantitative measures. However, what did the clients actually tell us? I want to come on to that ontological business again. That is similar to that diagram I showed you earlier. We have these program activities that we're doing, and they're producing outcomes. But what are the underlying mechanisms? What is their reasoning? What are their collective beliefs? What are the mechanisms that are important in the program? Because normal implementation science would not look at these. So this paper is in press, I believe. That's right. And so what we've found is that the clients and our partners believe that having a whole family approach, where we're looking at the whole family, not the child, was a very important mechanism. So in the center of this diagram, we have families participating in the decision-making, the development of trust with families, and cultural sensitivity as being critical mechanisms in this whole family approach. Another one was the flexibility of our delivery. Many interventions, as you'll be aware, have got strict fidelity around the original scientists decided that you had to do A, B, and C. And if you deviate from A, B, and C, then you're breaking the fidelity of the intervention. And so there's very strict protocols, for example, with sustained nurse home visiting from Professor David Old's work, the very strict protocols on how you actually do these interventions. A lot of our vulnerable families are quite disorganized, dysregulated, I think is a perhaps more clinical term to use. And they do not engage well with the programs that have the strict fidelity whereby you must visit every week and you must do what the program book tells you to do. So the flexible delivery of the wraparound model appears to have been an underlying program mechanism whereby the priorities of the client were paramount rather than the objectives of the service, where the clinician had autonomy to adapt what he or she did according to the needs of the family. This is perhaps the most important, we believe, underlying mechanism, and that is trust. And this trust works at several levels, which I'll show you in the subsequent slides. Fundamentally, there has to be trust between the clinician and the client. Those of you who are familiar with intergenerational psychological trauma, which results in conduct disorder and antisocial behavior later on, will know that people who are afflicted by that don't trust other people. And so when we're working with families where the parents have been exposed to intergenerational psychological trauma, it's understandable as to why this mechanism, that is the building of trust, is so fundamental. So establishing trust, building rapport, flattening the power base, using non-judgmental approaches, and having the interpersonal skills amongst the clinicians to actually do that. I'm not going to go through these slides in detail. I decided to leave them in the slide pack so that you can look at them later. This work is under review at the present time. We hope it will get published. So I'm just going to show you that it's ontologically layered. So you've got the consumer level, you've got the service level, and you've got the system level. You probably can't see here because it's too small, but I can assure you that underlying mechanisms at play at the consumer level are empowerment, encouragement, mutual respect and trust, knowledge acquisition and motivation. So trust is one of the mechanisms at play at the consumer level. At the service level, it's important that our partners trust each other, that social workers and doctors and nurses and community workers are able to work in a trusting way. So you can see at the service level, collaboration, believing in positive change, experiential learning, and again, mutual respect and trust are important mechanisms. And finally, at a system level, trust doesn't figure here, but I believe that even amongst at the macro level, agencies need to trust each other. They need to cooperate, they need to encourage each other. And so again, relationships are very important at a macro level. So in concluding, key features are that all these agencies are partners. There was a strong planning and steering committee. The program was family focused and met all the needs of the family was in scope. One of our partners, the chief executive of a primary healthcare organisation, coined while we were writing the grant application, everything must be in scope. Not just mum's diabetes, not the child abuse that's occurring, but also the housing, the food, the fact that mum doesn't have a driver's license. Everything needs to be in scope. It needs to be sustained longitudinally over a long period of time. And we had a problem, as I'm sure you may also, of agencies passing the parcel from one agency to the other agency to another agency and then back to the original agency. And so it's really important that we not have this continual referring to other agencies and then dropping this passing the parcel approach. We wanted to break that. The place-based work was important because we couldn't do this across the city of 1 million. Sydney's population is 6 million. Our city was 700,000. We couldn't do it across the whole city. It was important to test this in these place-based initiatives and then to start to expand it. So currently we've expanded it to 2 other communities. So finally, wrapping up, critical realism has provided the ontological, methodological underpinnings for this program of work, which actually started in 2007 with my own personal doctorate on maternal depression. And then it's underpinned the program of work. It's assisted us to explicate both the contextual conditions as well as the underlying causal and program mechanisms, noting that they are actually different. Consequently, we've been able to move from our earlier theoretical models, which I showed you in an early slide, towards the design of a whole of health and social care system intervention. In so doing, we have moved from causal and programmatic mechanisms at individual level towards mechanistic propositions related to service systems and providers. So originally, the original research was done at an individual level and created various propositions about the mechanisms that were at play. We use that earlier research to translate it into service system change. Those situated activities, both the face-to-face activity, the intermediate level of social and service organizational mechanisms, continue to highlight the importance of trust and also the importance of the willingness of us to share power with the client and with each other. Thus, the development and implementation of system change initiatives such as involving general practice, having health homes, having interagency task forces are very important approaches to sharing power, not only with our clients, but also with each other. So thank you very much, and I'll hand back to Tan. Can you stop my sharing?
Yes, please. Thank you, Professor Eastwood. Yes, okay, thank you. Now I can see you. Thank you for the presentation. Well, what stood out for me are two things, I must say. First is the use of collaborative design, which you mentioned pretty much early on in your slides. I'm quite intrigued about the co-design of integrated care for families, the involvement of multiple stakeholders in this. And the second part, of course, is the use of the realist approach to evaluation of this rather complex intervention. So yes, thank you very much for your sharing with us. Perhaps I can start the Q&A session by first looking at the pigeonhole. Yes, we do have a lot of questions up there. Okay, perhaps maybe I'll start with a question about realist evaluation. Okay, there's a question about, yeah, all right. So a member of the audience asked about the strengths and the weaknesses of using critical realist evaluation as an approach for evaluating complex interventions. Yeah, so perhaps another way of asking is, what do you think is the value add of realist evaluation, and how can it complement what we already know about the more common types of evaluation approaches out there, like outcome evaluation?
Sorry, like what? Like what evaluation?
Outcome evaluation.
Outcome evaluation, yes. Well, if we look at outcome evaluation, then we use randomized controlled trials and various types of those sorts of design methods, including quasi-experimental design methods. We're focusing on the outcomes. And if we see no change in the outcomes, we don't know why. And if we see a change in the outcomes, we don't know why. We think it was our implementation. We publish a paper and we say, our intervention resulted in a change in the outcome. But so what? What part of the intervention worked? Sometimes, as we know, it wasn't what we think was what made the difference. It might have been something else. So that is where we've now moved in complex evaluation to a mixture of process evaluation and outcome evaluation. That's well described in a lot of the MR's Medical Research Council documentation around this. And it's also another chapter in the integrated care books. So if we're going to do process evaluation as well as outcome evaluation, what type of process evaluation should we use to unpack what's inside the black box? I'm not saying realist evaluation is the only approach. There are many other types but most process evaluation will be mixed method. It will have a qualitative component, not only qualitative, because you might want to look at, use some psychometric tools as we did with the patient-reported measures or patient-reported experience measures to support the interviews and focus groups that you run to find out what was going on inside the black box. Why did it not work? Why did it work? So you're really answering that question of why. In terms of critical realism versus scientific realism, which is more Pawson and Tilley, there's not a lot of emphasis in Pawson and Tilley's work on historical context. That is, before you started the intervention, what was the situation at that stage? And sometimes there has been something happened in the last year or the last 10 years that is actually why your program is not going to work. For example, there might have been a falling out among key stakeholders. There might be two of the agencies don't like each other and won't share information with each other. There might be some breakdown in some policy issue. So there may be something about your community, which is why it's not going to be easy to implement your program. So critical realist evaluation does have a focus on the historical context. The other thing is that it does this micro, meso, macro, which a lot of Pawson and Tilley's work doesn't do. I'll stop there, Robin, so that you can move on to another question.
Yeah, perhaps another way to put it is that Well, I mean, I suppose the realist approach tries to address, the how and the why questions as part of an evaluation. And of course, there are other qualitative methods that can answer the how and the why questions. But for something to be considered realist, there must be the mention of context, mechanisms, and outcomes, which you have put it quite clearly in your slides. So my next question is to do with mechanisms. So if I may rephrase one of the questions from the audience is that, do you think there are mechanisms from the logic models that you have mapped out, for example, prioritize clients' needs and trust, that are universal, which means are they also transferable to the context of Singapore?
Yes, well, this is why it's worthwhile having a look at. As you know, in traditional scientific methods, we use systematic reviews. And we use systematic reviews because we want to see if other studies have found the same thing and whether it's transferable. So in realist research, we use realist synthesis. And I didn't present a slide on this, but we very much drew on the work of Tyler from Canada and a realist synthesis that she had done. And so, yes, I think in her study, her realist synthesis, trust, provider confidence, I think were two mechanisms that I can remember. I'm just having a bit of trouble tonight to remember the other two, and that they are transferable. We used their work a lot, and we were constantly surprised that their realist synthesis was very much in tune with what we were finding. So as more realist studies are done, we might have similar findings.
Yeah, thank you, Professor. Perhaps I'll take some liberties to ask this. This is still specific to mechanisms. In your slides, one of the mechanisms that you managed to elicit from the study is that families participate in decision-making. Yeah, so that's the mechanism that you have outlined in one of your slides. So I'm just wondering, if I'm thinking as a practitioner, how do you translate this mechanism into practice, to rebalance the asymmetries of power that we know exists, between the professionals and the client? How do you do that in practice?
Well, it was around, for us, I'm going to tell you, some of what I'm going to tell you is not entirely true. New South Wales had 10 years of training its workforce in family partnership training. So the mainstream workforce within Central Sydney has been working for a long time. The training was done at both practitioner level and management level about the importance of working in partnership with clients and avoiding that power in differential. The clinicians that we employed used the same approach, but actually they had not done the training. but they were very experienced social workers and nurse clinicians who had that training in another way, but the outcome was the same, that they worked in a partnership way with their clients. And I think they were working within a service system whereby that was the expectation. I don't know if that answers it, Robin. I mean, it was around capacity building of the clinicians to practice in that manner. Okay,
yeah. I certainly see there's perhaps there could be contention here, because one of your slides, once again, the mechanisms is about prioritizing the client's needs versus program outcomes. As we all know, program outcomes are driven by funders, donors, because they have funded the program to look a certain way to achieve certain outcomes. And there could be some contention with the prioritization of clients' needs. So once again, how do you translate that in practice?
Yes, that's a very tricky one. So the Sustained Nurse Home Visiting Program was a scientifically validated David Old's work and the MESH study, randomized controlled trials, and that works that works well for a lot of families, but the families that we were working with failed to engage with that program. So we would never get the program outcomes that we wanted with using sustained home visiting. So the reason we did this work was because we were looking for something else that we could use for families that were too dysregulated or antisocial in this context, may I say that, to actually engage with us, too distrusting. They didn't trust us. So we have to spend a lot of time, a year, 2 years, building trust. And only then can we start to deliver the evidence-based program of triple P or family forms of family therapy. So we've got to get to that level of trust that we can actually use evidence-based interventions.
Okay, thank you. I think that's quite key insight that you just highlighted. Yes, so I think this also answers the question that we have about the key takeaways about building trust. So what you're saying is that we need to prioritize the client's needs first before we can engage them into programs with program outcomes. So the client's needs must come first before we talk about putting them in the different programs that they potentially benefit from.
Yeah.
Okay.
Yeah, that's right.
Yeah. Okay. So if I may move on to talk about context now, there's a question about from Adam, about critical infrastructures. Okay, so what would you say are the critical infrastructures that such a holistic service system need to have in order for it to function effectively and efficiently? So I suppose this is a question about context. What kind of context needs to be in place for this kind of holistic service system to operate?
Yes, I'm hoping that the next piece of research we're doing might unpack that a bit more. But if we go back to the slide, one of the last slides I showed, which was the system level context is in that slide. And without looking at the slide now, I'll try and just talk to it. Is that collaboration, well, go even higher up the system than that. Strong interagency cooperation. Now, the context there is that the state of New South Wales implemented a Families First initiative in 1999 under a Social Democrat government. And that program, Families First, was an interagency collaboration between health, education, welfare, and local government. And it was in place for 15 years. The government changed to a Conservative government. When we were doing this program, that Social Democrat government was no longer in power. But all the agencies had been working together in a collaborative way for a very, very long time. And they trusted each other. And despite the fact that the education sector went through a reform process in the middle of us implementing this project, they still came back on board later, and every steering group meeting, there was always someone there from education, but that person kept changing, but they hung in there with us. The other thing that was critical was that there had been funding of interagency collaboration meetings at local community levels as a result of that former government, of the earlier government policy. And even though the government had changed, those interagency meetings continued to occur. So there was a context of partnership and collaboration amongst agencies and amongst non-government agencies. Now, there had been competitive tendering for government funding, and that had been creating tension between the non-government providers. So that is context as well. So some of the providers, so at a macro level, the agencies were working together, but at a meso level, some of the providers were not trusting each other, were not communicating with each other. And so we actually had to do a lot of work on that, so that in one of the communities, Riverwood, we didn't make the same progress that we did in the Redfern community, where there had been a lot more building of trust amongst the agencies. So when we go back, we know that one of the place-based initiatives did actually work better than the other one, despite the fact that the interventions were the same. And I think that's down to context. For example, we did not get good engagement of housing in one of the place-based initiatives, but we got very good engagement of housing in the one that I showed you, in the Redfern one.
Okay. All right. So I suppose you have covered some of the insights that you've shared. Address this question that's coming up next is about what are some of the considerations for expanding or scaling up care coordination programs, right? So I suppose what you've just mentioned can address that, but would you like to give more insights on this? You know, if one is to think about scaling up or expanding care coordination programs island-wide, what are some of the challenges you've faced, and what are some of the contexts that needs to be in place before this can happen?
Yeah, well, we identified a number of communities where we wanted to scale it to, and we still haven't implemented in one of those communities because I guess we just don't feel that the agencies are working well together. There's some community discord going on, and we have scaled to 2 other communities where we feel that there's a readiness to work in this way. And some of that is I wouldn't say it's a community co-design, I'll be honest with you, it's more of a top-down design. It's actually where the agencies feel that they're able to work together in this community, but they're not able to work together in another community for whatever reasons. So we went to Marrickville and Glebe as our second communities because the context was conducive for us to do that. But there was another couple of communities where we still don't feel we're able to, and that's why I said earlier on, why realist research and process evaluation is important, because if you did your intervention in that community and it didn't work, you wouldn't know why, unless you'd study the structure and agency stuff that's going on in that community.
Yeah, so from what you just explained, it seems like when you think about scaling up, you think about replicating an intervention across different sites, it's not quite a simple matter.
No.
It's not quite a simple matter of merely repeating the intervention in someone else's backyard and hope for the best that you will succeed. So what you are trying to tell us that there are different contexts at play, and if the context is not favorable, which means the intended mechanisms which you have shared with us will not be activated, and this would maybe affect the outcomes that we want to achieve.
Yeah, and that's why critical realists' approach to hierarchy of mechanisms is important, because you need to look at the macro interagency relationships, willingness to collaborate. You need to look at the meso level, the willingness of managers and teams to work together, and then hopefully you've got a favorable conditions to work with the clients themselves. So if you go in and work with the clients, but you can't do a whole of system wrap around the client, if the agencies won't work together. And we haven't got into some of the detail around practice models, sharing of information, agreeing to come to practice review meetings. What I'm trying to say, your discipline is very familiar with what I'm talking about, I'm sure. If you can't work together with a local general practitioner or the local schools, and they won't communicate the psychological findings from their testing with you because of privacy concerns, it just makes it very, very difficult to work in a family-centered way.
Okay.
Well, sorry, in a trusting relationship with your colleagues. Yeah.
Okay, so right now I'll move on to this question that is about the realist approach in general. Yeah, I see a set of questions about the intervention. Yeah, I'll come to that in a little while. Yeah. All right. So this question reads: the realist evaluation is conceived as a cycle to improve the theory. So when is a good juncture to move forward, where improvement ends, and to launch the evaluation proper? Perhaps, would you give some advice on when is a good time to start thinking about realist evaluation, and conduct this?
Well, this is a very tricky question, because if you start to embrace improvement science as well as implementation science, then you have continuous improvement. If you do it in a more academic way, you would implement it, study it over a 3-year cycle or a 5-year cycle, and then do it again. And so you can publish lots of papers like we are. But if you think about it in a more transactional way, which is what's happening in New Zealand, we're actually proposing that communities continuously look for insights in how to improve their outcomes. And we are thinking about asking them to report to us every 3 months on what they have learned. So it's going from an academic approach to the cycle to a more action research approach of doing this. A lot of those plan, study, do, act PDSA cycles don't ask the question why. So I'm actually thinking about they need to have a realist approach to their methodology, so that they are constantly asking what is happening and why is it happening. And look, I'm not answering your question properly. I'm just trying to say, from an academic programmatic point of view, you could do it over a 3-year cycle, or you could, as Scotland did with the rollout of its child wellbeing strategy, just use a quality improvement approach. And let the school decide, let the community decide how rapidly they're turning that cycle around.
Okay, all right, thank you for that. Okay, I will move on to the questions, to the group of questions that's specific to the intervention, Healthy Homes and Neighbourhoods, I believe. So yeah, so there's this questions about the program itself. So in this interoperability dynamic of serving care recipients, in this case the clients, who takes primary ownership for the care and services provided?
Please say that again.
Yeah, okay. So for this intervention that you shared with us in your slides, who takes primary ownership for the care and services provided? Because this intervention is about a long-term care coordination for families with complex needs. Yeah. So who takes the primary ownership?
Well, you might have noticed that we had a thing in there called shared care.
Can you tell us a little bit more about that?
Yeah, and also multidisciplinary teams. So I think it's a moving thing. So basically, our practitioners will instigate and engage, and then this was a very significant issue for us, because we didn't want to have to pass the parcel. So you engage with the patient and then refer to the doctor or refer to the social worker, and then they do something and they refer to the teacher or they refer to another agency, child protection, constantly passing the patient to someone else. So what we decided to do was to provide long-term underpinning of the whole intervention, but that we would be working with partners in a shared way. So there might be a child protection intervention happening, but because of funding problems, that intervention would only be possible for 2 years. So what would happen when the money stopped? We would then have to pick it up and see if we can find another provider. So that was that shared relationship between the program practitioners and our partners. It's not time tonight, and I might not be the best person to answer the question, but that was the idea, to not drop the parcel, to stay engaged long-term and to work with our partners.
I see. All right.
And that's how wraparound works. So it's a change in model. It's difficult, I know. Yeah. It's a new way of thinking.
Okay, thank you very much. So on a related note, still staying on the topic of the intervention, because there are a lot of questions, a lot of curiosities about the intervention. So what would you say is the criteria for the graduation or the successful exit of families from this program, such that they can independently manage on their own? Yeah.
Yes, so I don't know, but there was, because there's a set of criteria whereby we have them red, orange, green, and we would step them through to orange to green. But with these families, they would often go back again. So there would be something would happen in their life which would flip them back into being in a risk situation again. So the reason I don't know is because that was a clinical matter that my team was working on and constantly refining the intake criteria, the risk assessment criteria, when they would graduate them to less intense home contact to, and remember what I said, we wanted to stay involved for long term. So even if they went to green, we still want to stay in contact, maybe with a phone call every 3 months, so that we're always there if things don't work out. But I know from a clinical practice point of view, the person who's asking the question would like to know the answer to that. I don't know. I'd have to ask the team.
Okay. Yeah, I mean, indeed, I suppose generally program designers, policymakers are interested to know roughly, what's the average time it takes for families to successfully graduate from the program. I suppose what you're sharing with us is to remind us that family life operates in a cycle as well. There are ups and downs. So what I'm hearing you say is that, well, they might do well in a certain phase of their lives, but they might come back to the system at other points.
Well, they had relationship problems with their partners, and partners would go to jail, and then partners would come out of jail, and we often would find that when the partner came back into the family, things would all change again. So I know that a lot of programs that have been designed would say, "Oh, we do this intervention for 6 months and then we graduate them." Look, we have got programs like that in New South Wales. They're child protection social work programs that are designed like that, and they only run for 2 years. And by the end of 2 years, you're supposed to have graduated. Well, the problem was that some families never graduated. So, yeah.
Okay. All right. Moving on. I'm not so well. This question is on a spatial mapping exercise. It's okay if you're not the right person to address this, because I know you're working with a huge team of many others. But one of our members of the audience wants to know, what is your key takeaways from the spatial mapping exercise for the disadvantaged families?
Yeah, well, actually, my PhD was a multi-level spatial PhD. I used Bayesian techniques to do the multi-level spatial mapping. So you can look my name up and find those papers published in spatial and temporal epidemiology journals. This particular study was done by a public health medicine trainee of mine, and we used family stress indices that were coming through from the pregnancy records and stress indices that were coming through from the social demographic, and developed a scale and then basically found those families in those streets where people were under significant family adversity. That's how we identified those areas. We used ArcGIS. We used the clustering techniques in ArcGIS, and if a cluster fell on a statistical area level 1, it got a plus, and those statistical areas that had the most pluses were the ones that were the most read. Sorry. And that's how we did it. We're both not necessarily all that scientific, actually. The more of the indicators that fell on us on a small area, the more it was positive. Yeah.
Okay. I suppose if you want to find out more, we have to read your papers.
Yeah, that's
because
right.
you have done a lot of work in this area. All right.
That study is published, yeah, in the International Journal of Integrated Care.
All right. We still have some time here. I would like to open up the floor for questions. If you would like to unmute yourself and ask your question directly to Professor Eastwood, yeah, you're welcome to do so.
I've got an answer to a question that hasn't been asked.
Sure. Yes.
Yeah, in logic models, and implementation science, they often evaluate the whole thing. Critical realism and realist evaluation are quite intense methods. You can only really study particular parts of the program. So we only studied certain parts of the program. We couldn't do the whole thing.
Yeah, indeed. So I've also gleaned from your presentation that there could be infinite program theories out there. But so you have to scope your study to only focus on the key program theories that you want to investigate as part of your realist evaluation.
That's correct. Yeah.
Okay. Questions from anyone here? Although I can't really see you, but feel free to unmute yourself and pose your question directly to Professor Eastwood.
I will make another comment just to say this was a public health intervention, not only a clinical intervention. And so a lot of the other elements of the program were around trying to improve health literacy, create health promotion tools that could be used, but I didn't discuss any of those. The other thing was I didn't talk about component one, which was identification, where we're using risk stratification techniques during pregnancy as one of the methods. But again, that's why I put the perinatal coordination paper up as something people might be interested in reading.
Any questions from audience? If not, I'll take some liberties to ask them since I'm the moderator. Yeah. Okay, well, we wait for the questions to come in. Yeah, I can ask my question first. Well, realist evaluation or realist research, belongs to the theory-driven family of evaluation approaches. So within the family, there's also the theory of change, which you have in one of your slides, the theory of change, and then you have realist evaluation. So at what point, do we need develop a theory of change, and do we stop there? And at what point, should we decide to do a realist evaluation?
I don't know. Yeah, I'm not. Well, I think we took the theory of change and in a way developed a program theory, some logic models and some sort of, but we, in component 9 of the contract that we submitted, we said that this is a complex intervention, so we need to do complex evaluation. And the Decipher group in Wales run a course on design and evaluation of complex interventions, and I had been fortunate enough to go to that course. And so if we're going to do a complex evaluation, we need to have a process evaluation, and you can either use pragmatic methodology or you could use realist methodology. They were the two that were popular on that course at the time. So you don't have to use realist evaluation to evaluate a complex intervention, but because my PhD had been in that area, I just carried on.
How convenient.
I mean, I was interested to understand how critical realism could be applied to program evaluation, and just kept reading around it and trying to understand it. Yeah.
All right. Okay. Well, more questions from the
I might say there
audience?
is actually a textbook on using critical realism for organizational studies, organizational research. Yeah.
Yes, like what you mentioned earlier, mechanisms can be at different levels. They can be the individual level, the meso level, the micro level. So I suppose, yeah, that will be quite an interesting approach, because most of the papers published tend to be at the psychological, social level. Yeah. And it will be interesting to look at mechanisms at the organizational level as well.
Yeah.
All right. Okay, so perhaps before we wrap up, one last question from me. All right, so in the local context, I suppose we are more familiar with outcome evaluation, and often it is the gold standard for evaluation. Yeah, it is the most rigorous, and you employ methods such as experimental research design, quasi-experimental research designs. So, I mean, where does realist sit? You know, is realist opposing to this outcome evaluation research, or can it be complementary in a way?
Yes, well, there's a paper published by Bonell, B-O-N-L, on realist randomized controlled trials. And then there's a lot of discourse in the literature about whether this was a good approach or not a good approach. So there are the proponents for realist randomized controlled trials, and there are the opponents of realist RCTs. So I'll leave it there really, just to say this is an ongoing debate. Personally, I think I'm a pluralist researcher, and I think everything makes some contribution. For example, if we had done a propensity score matching quasi-experimental design and were able to demonstrate that the families were not going to hospital anymore and the children got better scores at age 8 at school, we still wouldn't know what was it about our program that was working or not working. So I think we might have known that our intervention worked, but how would we improve our program if we hadn't had some sort of understanding about what it was about the program that was actually contributing to those outcomes? And I haven't talked about the individual level outcomes, which that we were using patient-reported outcome measures, and I haven't talked about that tonight, but that was another tool that we were attempting to use. So PREMS and PROMs are being used extensively in Australia at the moment, and for highly literate, well-educated people, they seem to work quite well. But for this client group, as I said earlier, we had a lot of difficulty using our patient-reported outcome measures and our patient-reported experience measures, partly because maybe our social workers didn't believe in them. for this client group.
All right. So if I may summarize what you just mentioned, is that outcome evaluation answers a rather specific question. Does the program work? Yes or no? Yeah. Whereas the realist approach can answer a different set of questions. What works, for whom it works, under what conditions, and why?
Yeah.
And perhaps if I may take some liberties to say that your position is that we are able to integrate the two approaches, because each evaluation approach can contribute to our knowledge about programs, especially when it comes to refining and improving the program, and also identifying the context that needs to be present when we think about scaling up the intervention across different sites.
Yeah, absolutely. Thank you, Robin.
All right. Okay, with this, thank you, Professor Eastwood, for your time today, for taking time with us, because I know it's evening time. Yeah, in fact, it's dinner time for you right now. Yeah. So thank you for being with us, spending your time with us. With this, I'll pass my time back to HHAN.
Okay, thank you, Robin, and for everyone who's joining us today. So I'll first launch the feedback poll. Okay, so Yeah, in the meantime, we would like to thank Professor Eastwood again for joining us at this time today, which is past 8:30 p.m. in New Zealand, and also Dr. Robin Tan for joining us today and moderating this session. Okay, so while you do the poll, just one last announcement. So if you are interested to learn more about realist evaluation, SSR conducts an introduction to realist evaluation workshop. So we offer also research capability development services for social service agencies that are seeking advisory services for longer term projects. So if you're interested in any of these, please sign up for our mailing list on the QR code on the screen to receive regular updates on SSR's events and workshops. And you may also wish to follow us on Facebook and LinkedIn using the respective QR codes on this screen. Yep, so feel free to follow us on any platform that's more suitable for you. Okay, I will close the poll. Right, so that's all we have for today. So we have come to the end of the webinar. Thank you so much for your time and for joining us today.